With so much focus on keeping ourselves and our loved ones safe and healthy, it's easy to forget that most of us are going to experience things like allergies, colds, possibly even the flu. So, reminding you, proper hydration is crucial for all of these things. Remember, even slight dehydration can make you feel like you're getting sick, and none of us need that anxiety right now, that's for sure. That's where Hydralyte comes in. Longtime fans will remember my obsession with Hydralyte, which is simply the best oral rehydration product I've tried. I'm even more excited to introduce their brand new single-serve powder sticks. Simply pour one powder stick into a glass of water. They recommend 7 ounces. The powder dissolves almost instantly, creating the perfect balance of sodium, glucose, and water. Delivers up to 4 times the electrolytes of your typical sports drink. The other great news about Hydralyte's new powder sticks, they're 100% all natural. No artificial flavors, colors, or sweeteners. They're available in flavors like orange and lemonade, and they taste great. Hydration is crucial, and Hydralyte is fastest and easiest way to stay ahead of it. Get your supply of Hydralyte powder sticks now at hydralyte.com/DRDREW. Again, that's hydralyte.com/DRDREW, and then use that code Dr. Drew 25 at checkout.
Hey, everyone. It's a dose of Dr. Drew.
Indeed it is. This is a show I've been looking forward to for quite a while. We're bringing our friend back, Dr. Yogendra. He's a board-certified anesthesiologist, background in public health. In fact, he was the infection control practitioner in a Florida hospital around HIV and AIDS. He also had studied tropical communicable diseases from University of South Florida. Of course, he has an MD and a board certification in anesthesiology. And if you've been watching along with us here, he has been an extraordinary source of information. We did a great interview with Dr. Patterson about all roads leading to Rantes and the leronlimab story. But today we're going to bring in a couple of special guests that he has brought with him. We're going to talk to Dr. Tom Purcell, who is the longest surviving ICU patient with COVID. And we're going to talk to Samantha Mottet, who is also someone who was in the, let's face it, the terminal phases of COVID and turned it around seemingly with leronlimab. Let's bring in Dr. Yogendra. Dr. Yo?
Hi, Doctor.
Hey, there you are, man. Good to see you. So thank you for everything you've been doing. You've been educating the world, and hats off to you for what you've been doing. Tell people about your podcast and your stream.
Yeah, so, again, thank you again for having me. I always look forward to talking with you on our Twitter exchanges too. I really started out doing this, trying to do health and medical videos and blogs for this health and wellness center that I opened. It's a little side business. And it morphed into something different, where I started talking a little bit about COVID and getting into COVID research myself. And really, the whole thing started from my friend, Dr. Purcell. He was a colleague of mine, former anesthesia colleague of mine at Rhode Island, and he retired and moved down to Florida. And when all this outbreak was going on, I was sort of in the sidelines. I'm not a researcher, I'm a clinician. I was watching the news and talking a little bit about it. But when Dr. Purcell got sick and I found out about it, that's when it gets personal when something like this happens. It's like, oh, I know someone now personally. I'm affected because they're someone I know is in the hospital. So I was following, we have some mutual friends, and I was sort of getting updates on Dr. Purcell's condition till he got to the point he was in the ICU. And then it was like, oh, well, what are his vent settings? What is this? And if our mutual friend said, well, why don't you just send his wife a text message? And I had never met Helen, his wife, before. So I dropped her a message and said, hi, I'm Yogendra. I'm a former anesthesia partner and friend of your husband. You don't know who I am, but can you just tell me? I like to help out. And from there, I really got involved in his almost day-to-day management. It turned out the ICU doctor that was taking care of Dr. Purcell was a friend of my dad's. My dad's a pulmonary critical care doc in Florida. So we immediately built a great rapport because he knew my pedigree. He knew who I was. It wasn't some random doctor that's...
And place this in time. When was this that you're going down there and managing in the ICU? Because I want to understand the phase of the sort of general medical understanding that the community had at the time.
This is probably about mid-April, mid to April 20th.
Okay, so by that time, the term cytokine activation, cytokine storm, this was common lingo. People were starting to look at inflammatory mediators. People were starting to use IL-6 inhibitors and things, but we were very primitive in our understanding, correct?
Yes, that's true, Dr. Drew. We were still kind of looking at it as a viral disease. The cytokine storm was starting to be talked about. And, when Dr. Purcell, when I sort of got involved in helping out or just following, it's funny, I had a giant spreadsheet on my kitchen table, then settings, labs, every day the doctor's calling me, okay, your friend has this, and I would suggest, well, can we consider this? And, that's another point I wanted to make was, in medicine, you've been around for such a long time, there's professional courtesy. We don't step on someone's toes. Some people say, well, why don't you go and tell them what to do? We respect each other, and we say, well, can we consider this? Could you look at this? We are very respectful.
It's a collaboration.
Absolutely. And especially when you're an outsider coming in, you never want to,
were you in Rhode Island at the time?
No, I was in Florida.
So you're in Florida. So would you actually examine Dr. Mottet? Dr. Purcell, Dr. Purcell.
No, he was in the COVID floor, and I didn't allow any visitors into the floor. No family, no friends, no doctors. But like I said, the nice thing was his IC doctor, just fortunate, was my dad's friend. So we immediately, he was so kind, gave me all his lab updates and whatnot. And what I started to learn about COVID was from trying to help out Dr. Purcell, really getting involved in his day-to-day management. And that's when I found out about exclusion criteria for remdesivir and tocilizumab. Because one of the things when I was talking with Helen and the ICU doctors was going, well, these are the medications that they're talking about now. Hydroxychloroquine. Well, he already got that. Okay, can we consider remdesivir and tocilizumab? No, we can't give it because exclusion criteria was 5 times the normal liver enzyme of the AST, ALT levels. And Tom's liver was, at this point, he's intubated, he's severely ill. And one of the in severe COVID is we know that the liver and the kidneys shut down. And this could be either due to either the virus from the ACE2 receptors or RANTES. RANTES plays a major role in liver and kidney damage. Right. And so he couldn't get those 2 medications. And that's when Helen and I, we were talking, it's like, well, what else is out there? And I started looking and researching and talking to people all over the country and friends of mine. And I came across Samantha Mottet's story and the story about leronlimab. And now you can see how this whole puzzle starts to fit in.
How did you find that story? Was it just a case report somewhere, or how did you hear about that?
It was a Google. I'm Googling like what's out there. What are the clinical trials? And this is the other thing, Dr. Drew, I really wanted to talk about was, I don't want this to be like a dog and pony show where people come in, we talk about, oh, these people had these infections and they survived. I think there's a real interesting story to be told, and also something we can all learn, because we talk a lot about the medicine. You and I are physicians. The medicine is exciting. It's fun sometimes. It's interesting. But there's a human element here. There are people we're taking care of. And they have an interesting perspective in how we can shape the future of medicine, the future of public health and healthcare. Right. I think it's very important because the families and the patients sometimes are not part of those discussions.
And in this case, we have a physician patient too, so it adds some extra sort of perspectivalism to the whole thing. So I think that is a perfect way of introducing our first guest, which is Dr. Tom Purcell and his wife, Helen. Tom, welcome.
Thank you for having us.
Oh, it's such a privilege. And we were talking to you guys a little bit off the air, and you seem great. Oh my God. I mean, how long ago was the last day in the ICU?
I moved out of the ICU, I think around April. I went in March 28th, was intubated on the 30th, I believe, and then moved out of ICU to a Advent Hospital in Daytona on April 8th or 9th, I think it was. Could have been the 7th. But I was still trached at that time, and I don't have any recall of that at all.
Do you have any recall of any of the ICU stay?
No.
Yeah. I think it's an important thing to point out, because for people that have friends and family in the ICU, the family and the friends are suffering, and they worry that the patient is suffering. The patient rarely remembers anything. And especially, did they have you down on propofol or something?
Yes.
Yeah. So we go to great lengths to keep people comfortable and unconscious when they're in ICU. So that's the first kind of perspective thing I wanted to get out of the way, because I know it's unbelievable when families just, they can't stand to look at what's happening, and they assume from your perspective the experience is horrible, which it isn't necessarily.
For me, it was not. For Helen,
Right,
and my family, it was a storm.
Well, it's the horror of seeing you so sick, but it's the horror of the danger of the situation. So, Dr. Yo, is there a particular place you want to start this?
I think we can, I think, Helen has probably a lot of insight and perspective. I've spent so many hours talking to Helen. It's funny, I never met her before. I never talked to her before any of this. I think Helen will really have the best perspective in terms of how this whole thing started, because I think you got the infection in Rhode Island and then you went back to Florida from your mother-in-law. So maybe we can start from there and sort of talk a little bit about your hospital course.
Well, I went down to Florida on the 15th of March. I wasn't feeling well on St. Patty's Day. And then what I did then was call the number that you're supposed to call in Florida. And it took them about 48 hours to get back to me. And by that time, I made an appointment with a walk-in clinic. I went there, and the physician, who was very nice, told me I had the flu, to go home and rest. So the following week, I wasn't feeling any better, so I went back to the clinic.
Were you very toxic at that point, or was it like a mild flu?
I was not remembering things at that point. And my wife can attest to the way I left my house. And I'm kind of a neat freak. And my house was totally trashed because I was leaving stuff open and out, and I'm not like that. The next physician did a COVID test, which they lost. And so that first COVID test, I have no idea if it was positive or negative. When I talked to my wife on that Saturday, the 28th of March, she said, you got two choices: drive yourself to the hospital, or I call 911.
And Helen, are you a medical person?
I'm a nurse anesthetist.
Okay, so perfect. So you knew that it was more, you knew what the signs of encephalopathy were, essentially. And even though he wasn't miserable, he was encephalopathic. He wasn't functioning right.
He was short of breath talking to me.
Okay, that too. Great. And did you have a sense at that point? Did you smell COVID, or did you have no idea? Yeah.
I got tested already and was COVID positive.
You were COVID positive, and you were an asymptomatic carrier?
No.
No, you got sick.
I had fevers, chills, short of breath, and my daughter had a high fever, was lethargic. My mother was sick, was quote unquote diagnosed with bronchitis from a walk-in clinic, and given antibiotics, which were not appropriate. But
so let's stop right here. So Dr. Yo, so our first order of business, our first observation is diagnostic sloppiness, and sloppiness in terms of the overall handling of diagnostic materials, tests. Do you want to make a point about that?
Yeah, absolutely. I think this has also been access to the tests have been an issue. The quality of the test, the sensitivity and the specificity of the test. And yeah, there have been cases of people losing their lab results because they're dealing with such high volume. A lot of these health centers and a lot of them were getting inundated. So it happens, lab errors happen in the hospital, but they're usually one or two cases here and there. And then we do a whole Q&A and risk management, try to figure out why. But these are egregious errors because we rely on these tests and the accuracy and the timely delivery to guide us in our clinical decision making.
But to me, the lack of careful thought is what I hear here. lack of caretaking, lack of care, lack of carefulness, and lack of careful thought. I mean, for instance, here's where I'm seeing this right at the moment. I'm seeing all these adolescents being diagnosed with Kawasaki syndrome, right? And I have seen some video clips of their rashes, and we're in the middle of a typhus outbreak. As far as I'm concerned, they have classic typhus rashes on their hands, and no one is thinking through, well, they're not COVID positive, but the whole family was COVID positive, and he's got this rash, and it looks post-inflammatory. That's what it is, as opposed to continuing to think through and rule other things out. That's bizarre to me.
Yeah, I think we sort of think everything is COVID now.
But whatever it is, it's without careful thought, right? Yes. Your job is to think it through, not to just impulsively render a diagnosis. Like, I'm thinking of the bronchitis, Helen, for your mom. I mean, it's just like, that feels to me like just somebody trying to move somebody through an urgent care center rather than thinking about what's in front of them.
You're right.
Yeah. Again, I'm going to say it again. I think a lot of the Kawasaki's, particularly here in Southern California, is typhus. I'm going to say it now. They need to detect the rickettsial titers, which they're all cared for by pediatricians, and of course they don't do that. So there's another layer of issues here, which is the people that are improperly trained are seeing people. You know what I mean? That we're so siloed now in our different disciplines that people aren't thinking broad. They aren't thinking broadly and widely. Anyway, I interrupted. Helen, you were telling the story about your household. I'll let you continue.
Well, I did take my daughter to the pediatrician the day after she had the high fever. And the pediatrician said, I don't think she needs a COVID test. But at that point, I wasn't tested yet, and I didn't know I had COVID. But my mother was never tested. And then when we're in Rhode Island, when Rhode Island came out and said that anyone who is a healthcare provider can get tested at these areas.
We have to remember what was going on around then. Remember, there was not good access to tests in many areas,
right.
And they were being restricted for very high risk and known exposure and all that stuff. Remember, this is the hard part about reconstructing everything. You have to go back into the fog of war. So we were good here in LA County, but I remember thinking of the rest of the country not so good because you had to prove exposure. That was that was a very silly thing, but okay, that was the deal.
Right. So I went and I got tested because I said, listen, I'm a healthcare provider. I would like to see if this fever that I just can't seem to get rid of, and my shortness of breath, and I don't feel so great. I mean, what's going on?
Yeah.
I don't think this is a sinus infection, because I also went into a walk-in clinic and they said, you have a sinus infection, and they gave me Zithromax. So they said they didn't think it was COVID.
Wow.
So I know it sounds familiar.
That's what happened to you too? Has that happened to Tom also?
He has a second story.
Uh-oh.
Yeah.
Well, when I went back to that clinic, that's when they lost the COVID test.
Right.
Yeah. The first time they told him he had the flu.
Yep.
The second time he walked in, they actually tested him.
But we never got the results to that. And that's when I went to the hospital. And from that point, getting put in a cubicle, I don't remember anything.
And that's when I jumped into action. I called the emergency room doctor immediately. And I said, listen, my name is Helen, and I'm a nurse anesthetist. This is my husband. He's a doctor. I'm COVID positive. He has COVID. And he said, yes, the chest x-ray shows bilateral infiltrates. And I said, yes, how often do you see that?
Right.
And I said, can we start him on, this? And he goes, well, we're going to use Zosyn. We think it's pneumonia. And I'm like, no.
So you had a high suspicion of COVID at that point?
Yes, because I said, I am COVID positive. They go, yes, but we don't have the test back yet. And I said, but aren't the roads looking like this? I understand. And Zosyn is not a great antibiotic. It's a nice one.
Right.
It's
a nice
a
one.
very powerful one.
Yeah.
It's a bomb. Okay. It's a bomb.
If you have Pseudomonas pneumonia, yes.
Yeah.
So.
But that's where we started. And then when he hit the floor, he started deteriorating on the floor. He was FaceTiming me and I could just see it. It wasn't looking good. And then I called over to ICU. You can tell I get a little proactive. I've been in the hospital for a long time. And
well, but as you're telling the story and Ram, as I think about what you were doing, Tom had advocates, ombudsmen, medical. This is what primary care is supposed to do. This is what primary care used to do back in the day. Again, another thing for me to complain about here. If you had a really talented primary care doctor you had a solid relationship with, that person should have been your pulling guard through this entire experience, and should have been the one constantly reassess. Not your wife, you know what I mean, and not your friend in Rhode Island. Thank God you had those two people. That really is probably why you're here. But
Yes.
there's a big indictment in this whole story, which is if you had high quality primary care, really thoughtful, really well trained, it might have been a different experience. We all
But
agree with
Dr.
that?
Drew,
Yeah.
most of the doors on primary care is if you have a high fever, call this number and don't come to our office.
Right, that's true.
What I
But again,
see in Rhode Island now.
but if you had a relationship, let's say the way I practice primary care is I would know everything about you, and so much so that we could handle so much over the phone. And if, just like with Helen was going, things don't feel right to me, I would have that same feeling. And if somebody said, Helen's COVID positive, that's what Tom has. I know Tom.
That's what
He
I
doesn't, Tom doesn't get bilateral pneumonias on a regular basis. He's a healthy man. I can vouch for that. And if we had this relationship, Ram, do you know what I'm talking about? I mean, am I getting this wrong?
No, absolutely, Dr. Drew. I think it's also there's a disconnect here with sort of our healthcare system and how we're practicing medicine. I think we look at a certain disease or the problem rather than an individual, and building those relationships. And I think relationships might be
well, but I can tell you somebody who's done this for many years. In that relationship becomes this sort of instinct, much the way Helen has an instinct about her husband. A primary care doctor has an instinct about his or her patients, because you just get a sense like, well, that's not something Tom does. Tom does not get bilateral pneumonia. What in the world? Was he around a parrot? Did he have is he having trouble swallowing all of a sudden? What this guy, it's out of the blue. It's weird. And so it would have to be something weird if it were not the fact that his wife's positive COVID test grounds it in something very specific. So, go ahead. I'm not really upset about this. I've been complaining about this phenomenon for many, many years.
Oh,
it's not getting better, as you know. It's getting worse. So
it is. I 100% agree with you. I mean, I'm an advanced practice nurse, and I see more and more now advanced practice nurses and PAs rather than doctors for general practitioners.
That may be a great thing, by the way. I don't know that that's not good. As long as you have a long-term, as long as you have a long-term, connected, thoughtful relationship with someone who's paying attention, and I would say that. And I would say the paying attention part is the most important thing, because sometimes I feel like our peers are sort of sleepwalking as they sort of hand off the Zithromax and the Zosyn and whatever.
But I would like to give a nod too, because I immediately, when all these alarm bells were going off in my head and no one was listening to me, I started calling out, and that's how I found Ram, Dr. Yo. Thank you so much.
And Dr. Yo, is this the kind of thing you were talking about when you said the family has perspectives on the shortfalls? Or is there something else? Did you have something else in mind specifically?
No, this is it, Dr. Drew. And Dr. Purcell's, obviously his story changed my trajectory. And there are many other families like him. This is a very common story, not only in the United States, but around the world, and families that have reached out to me just to get advice, just to get a second opinion, just for support. Just to hear another physician give them support, and this is a very common story.
The common being tossed around places before you end up in the hospital.
Tossed around in places, just families are very confused. I mean, in Tom's situation, he was very fortunate. He had Helen, a lot of our friends, all physicians, but just think about families that just don't know.
That's what I was saying. Not only did he have Helen, he had you. right?
Yep.
And we're able to, and the other thing too, we understand the management, so we could ask doctors not question them for the sake of question, but just to understand. Okay, now we have okay, they're doing this, and this is the reason, and this is why families reach out to me, because they said my loved one is getting this medication and they're on this ventilator, and this is what the doctor said, but we don't know what it means.
Right.
People
What do you
just want
mean?
an explanation.
Oh, say that again. I'm not sure I caught you.
The families, the
Yeah.
families, they want to know what is going on, and they've been presented with some decision making, and they just
Right.
want to get a second opinion.
Right.
We have a different Tom and Helen had a different perspective, being in medicine, and our friends, we could talk about it.
Yeah.
So, and this is what I just wanted to highlight was these are the behind the scenes discussions and things that families are facing. While we're talking about leronlimab, all these exciting medications, they're real life implications. There are people suffering because of this.
Oh my God. Yes. Well, that's for sure. Helen, you're saying something?
Yes, Dr. Drew, if I may. The first person I started calling everyone I knew and everyone that I worked with Tom for years. And I called one of his medical school colleagues that we worked with, Dr. Guy Lancelotti, who is a vascular surgeon I've worked with for years. And these guys love each other. So I was like, Guy, you'll never believe what's going on. And I said, please help. And of course, it was Karen, his daughter, myself, his son, Tom. I mean, we were just trying to call everyone we knew in the medical family and say, can you please help us with the management of, for Karen, it was her father. For me, it was my husband, and Dr. Lancelotti got involved as well. And not only Dr. Lancelotti and Dr. Yogendra, but VJ, another anesthesiologist, got involved. And then we had a cardiothoracic surgeon that we used to work with get involved. But a lot of people don't have these resources. They don't have these friends.
Nobody does. Yeah, this is the problem.
And this is the problem.
I agree. Dr. Yo, is there another stage of the illness you'd like Tom to talk about here?
Yeah, absolutely. So, so I think eventually Tom ends up in the ICU and he's intubated. And that's sort of how, when I kind of came into the picture and getting in touch with Helen and the rest of his family, Karen, his daughter. I think probably Helen, well, let's talk about your perspective here, because we can talk about the ICU management, the medicine, but really Helen and I spend many hours talking on the phone, 3-4 o'clock in the morning. Then we text each other at 7 in the morning. It's scary in the ICU. Now, when you're a physician taking care of ICU patients, I don't want to say robotic, but you have this checklist, you're going through these things and you got to try to take care of this patient and doing the job. It becomes personal when it's someone you knew, it's a friend of yours, a colleague. So there are feelings and emotions that you're very vested in that, emotionally, in that situation. So for me, the challenge was trying to separate, because sometimes I would get off the phone with the ICU doctor and Helen going like, oh my God, like, I think Tom's going to die. I think I privately told this to a friend of mine, a mutual friend. I think he's got 24 to 48 hours, liver failure, kidney failure, on dialysis. He's intubated. His high PEEP, he had a PEEP of 20.
On 100% O2?
On 100% FiO2.
Yeah.
They did the ARDS protocol, low tidal volume.
Yeah. And
then
was he shocky also?
Yes.
Bleeding?
He was bleeding.
Yes.
Dropping in hemoglobin.
Yep.
Helen,
So did we leave anything out from COVID, from the cytokine storm? I guess.
Yeah.
No, he got it all. Okay.
So he had
AFib,
Oh,
160s.
MI, cardiac arrest.
What?
Yeah, when he coded.
Now, was that part of the shock, or was that because, do you have coronary disease?
No.
So this was just the hyperdynamic state you were in, right? It was so what happens, and this is for the audience at large, when your heart when you're older guys like us, and your heart first of all, it's an atrial fibrillation, so it's going at an abnormal rate. Then its demands are excessive. It's it's worse than, playing a football game or something. It's physiological demands are excessive. And so you outstrip the ability to supply blood to the inner surface of the heart. So you get these endomyocardial damage. Is that what happened?
Yep.
Yeah.
Yeah, I was, before this, I was swimming 2 miles a day.
Well, I think what's interesting, you don't have heart disease. And was there a myocarditis also, do they think? Or were they scratching their head like maybe this is just myocarditis and not an MI?
They didn't call in a cardiologist for a while. I asked.
Thank you.
But let's not get into that.
Okay, Dr. Yo, back to you. So we're in multi-organ failure. We're shocked, multi-organ failure, cardiac ischemia. And would be reasonable to say we have 48 hours to turn this thing around.
Yeah. So I think. So Dr. Purcell coded. He had a cardiac arrest at I believe 5:30 in the morning. I got a call from
and just when he had VFib. What happened? Just shock.
I think they did chest compressions for a couple of minutes. I don't remember how long it was. I think about 3 or 4 minutes. They did chest compressions, and so I get a call at 8 o'clock in the morning from the ICU doctor. He goes, Ram, I don't want to scare you, get you upset, but your friend Tom, we had to do chest compressions this morning. So now I'm immediately going, okay, he's got a couple of hours now.
Right.
But this is the real interesting thing what the doctor said. His mental status is the best I've seen since I got on service. And that was about a week.
Meaning he was on propofol, he was awake?
He became, they had shut the sedation off. They were doing sedation trials and they would wake him up. But after he had his cardiac arrest, he was more responsive. Can't explain it. It was, I will tell you, I used to do a lot of ICU work and I was concurrently doing a lot of psychiatric care. And sometimes I would see the same patients cross over into the ICU and then back into the psychiatric setting. And a good episode of shock will do the same thing as electric shock therapy. It makes you alert and your affect is bright and it can go on for a while. So let's just sort of say maybe it was that. Now, question I have is, did he have other underlying, Tom, did you have antiphospholipid syndrome? Are you hypercholesterolemic? Are you metabolic syndrome? Nothing. Okay.
Nothing.
Yeah. Which is because what I saw, that kind of a storm is with folks that check all the boxes in terms of risk factors that we're now all familiar with, but you were doing it in spite of that. So keep going, Dr. Yo.
So so then after that, we were trying to figure out, sort of medications and therapeutics. And as I mentioned, I think Tom on admission got hydroxychloroquine and azithromycin. Didn't respond to that. And then I think Helen and the family were considering tocilizumab and remdesivir. And at the time, these were still, especially remdesivir hadn't been granted the EUA, so it was still an experimental drug. I believe same thing with tocilizumab, which is the rheumatoid arthritis medication.
He got both?
They were considered for him, but he couldn't get it because of the exclusion criteria of the liver enzymes. So now he's all these things going on, and that's when I started researching and stumbled upon Samantha's story and what the team at UCLA, Dr. Yang, and the infectious disease doctors were treating her with. So then I told Helen, there's this drug called leronlimab. I don't really know much about it. So we both got on a conference call that I think Cytodyne did a investors conference call. Do you remember that, Helen?
Yes.
And we were both on the call just trying to learn about this drug. And we got in touch with people from Cytodyne. And the really nice thing was the ICU doctor, because he knew my dad, said, I will consider leronlimab. I said, look, it had a great safety profile. They had 800 patients they've studied on HIV. So he started looking into EINDs. And what EINDs is an emergency investigational new drug. This is the first time I even heard about this. And it wasn't part of my training in medical school or in residency. I don't know how to get an emergency use drug. I don't know how FDA works. So this is an eye-opening experience for me. And I don't think many of my colleagues do. The ICU doctor asked me, how do I get this?
Wait, when do you have that experience in normal, so to speak, normal day in, day out practice? It doesn't happen.
Exactly. And this ICU doctor was, he's got 20 or 25 years of experience, incredible doctor. And he's asking me, how do I get this drug? So I'm going to call with him on the FDA website, trying to figure out what's the process. And, this is just something also important, Dr. Drew. I talk a lot about these new experimental drugs, and people ask me, well, just give it to them. It doesn't work that way.
Right. You can't do that.
You can't do that. The ICU doctor has to be the principal investigator. Hospital IRB, that's the research board, has to approve it. The CMO, hospital pharmacy, the infectious disease. There are so many players, and along with the family consent, and then a packet gets sent to the FDA. They review it, and they may or may not.
How did you get through that process, and how long did it take?
I will say the Cytodine was very supportive. That's the first time, I just dropped him an email. Neda Porhasan is the CEO. And I think we got on a couple of emails, Helen and I. And
did
Karen,
they walk it through?
They helped out. Yeah.
Okay.
Dr. Kush Dodi from Amarex sent the whole protocol. The ICU doctors started talking with Cytodine about getting leronlimab. But this is the thing that we stumbled upon. The trials, the clinical trials for leronlimab and COVID were not on the clinical trials site, the clinicaltrials.gov site.
The government site.
The government site, correct. So we were going off their HIV information. And on their HIV information, their exclusion criteria said liver enzymes are elevated. Now the ICU doctor's going, well, I don't think we can give leronlimab because of the liver exclusion. Cytodine is saying, well, no, there's no exclusion criteria.
For COVID.
For the COVID, we went I think about 2 or 3 days just going back and forth. The ICU doctor was not comfortable at that point. And I got to give him a lot of credit. He's just a wonderful, wonderful doctor, went out of his way. And you have to spend several hours really going through this process. And when you're busy in the ICU, I really commend him. Unfortunately, he was off service on that Friday, and the other doctor came in, another ICU doctor, who also knew my dad, and calls me up on Saturday morning, and he said, we're not considering leronlimab. We're not considering any experimental drugs. Called me at 8 o'clock in the morning, and he said, are you working for Cytodine? I go, I don't even know these guys.
Oh, God.
And his exact words were, what's your stake in this?
Oh, boy.
And I said, my stake in this is because my friend is dying. I'm going to, and that's when that's when that desperation, I felt desperation. And I started to empathize what other families and other patients are going through in this country. That feeling I got off the phone was, oh my God. I just had another physician berate me because I'm just trying to look for something. And I got on the phone with Helen and Karen. I said, this is awful. I had never been, I can't believe someone would speak this way to me. I was actually pretty upset. And what was really upsetting is, they were trying, some of the doctors that were trying to get a DNR, a do not resuscitate order on Tom. And I don't think a lot of people know this, but I did a neuro check on, I FaceTimed him. He was in the ICU. And one of the things a lot of people have to remember, a lot of these patients are alone. Tom's alone in Florida, all by himself. His family's in Rhode Island. I'm about 30 minutes away from him. I can't go see him. And he's in this little bubble room, and I FaceTime him, and he's all bloated. If people know ICU patients, you're in there for several weeks. They're edematous, a lot of edema. Yeah. And he's, I think he was on a trach collar, and I'm talking to him. I'm like, Tom, I just want him to see any response, and he's just staring at me on FaceTime. And then, we have a mutual friend of ours. He's an anesthesiologist. He's a character. And everyone wrote out, he's a really lovely man, just a character. And I started cracking jokes about him. He's a longtime partner of Dr. Purcell in the anesthesia. And I started cracking jokes and saying things about him. And Tom busts out laughing. And I knew he had this smirk on his face. He started laughing. Yeah. And I said, Tom is intact. He's able to process. His cortex is functioning. I don't know about his brainstem because he's not moving, but he's able to process information. And I got on the phone with Helen and Karen and said, do not sign that DNR. Your dad, your husband, he is still intact. And I just, it was this whole thing was just such an eye-opening experience for me. I saw a different perspective from seeing what families are going through. And that's why I'm very grateful you could have all these guests on today, Dr. Drew.
Well, thanks for bringing them and telling the stories. Tom, any long hauler symptoms? You've been through a long haul, quite literally, but I almost, to call you a long hauler almost misses the point, because you've been, your disease started as a long haul.
I think the one thing that Ram missed was the convalescent plasma I received.
I got him convalescent plasma.
So,
right.
But with friends like Ram, who needs convalescent plasma?
Yeah,
crack jokes when a guy's got a trach in. Go ahead. Yeah, nice.
You do the convalescent plasma, though, let's be fair. Ram's good, but the plasma is even better. But
he got dialysis the next day, so we don't know.
Oh, interesting. Well, interesting. That's an interesting question. That's for later research. Because I'm sure a lot of the folks getting plasma are on dialysis too. So are you left with any symptoms other than you mentioned some neuropathic symptoms?
I have neuropathy in both feet, which is in my family, so I don't know if that's part of the disease. I'm still learning to walk again. I'm using a cane, so I'm out of the wheelchair, I'm out of the walker. I get around with a cane. My strength is coming back. My right hand is functioning. My right arm came back. I think when they put the permacath or the AV access in, they hit the brachial plexus.
Oh boy.
And when they took it out, my arm swelled up as big as my thigh.
Did they do an ultrasound? Did they do an ultrasound of the venous system on that side?
No.
No. Interesting.
I had a blood clot in my iliac vein.
You were already on blood thinners probably there for that.
Yep, because of the AFib. I had a GI bleed.
Hang on a second. So you think that iliac vein clot? Wait, because of the atrial
fib. Oh,
you're on a coagulation because of the atrial fib. Got it.
So whether the permacath in my right femoral vein caused the clot, the thrombus, I don't know.
I get it.
But we ended up with an IVC filter.
Oh, good times.
Yeah.
Which we still have in.
Yeah. Are we going to do something?
That's the only thing left.
Because that's a little controversial itself. Any plans for that?
I'll have it removed when I go back to Florida, probably in November.
Great. Well, listen, Helen, please.
I would like to say that Dr. Lancelotti, as Dr. Ram, he knows him as well, but Dr. Lancelotti did sit down with his son and his daughter and did say this was a viral process, and got to sit down with him because I was in Florida during the time and I needed somebody who knew the family. And since Guy went to school with Tom and knew his family, sat down with him and said, this is a viral process. Your father, very healthy before going in, and this is a virus. So, we do not need to make him a DNR. He can live, he can beat this. And that is the attitude that I had and we stuck with, and that he conveyed to the family. So that helped out so much. But once again,
it's not a terminal illness per se.
No.
It can be deadly, but it's not a terminal illness. Dr. Yogendra, anything else we want to talk about with our friends, or before I let them go, we're going to bring our next guest in?
No, I think we, thank you, Dr. Purcell and Helen. Thank you very much. I know, it's these are very personal stories, and as I said earlier, Dr. Drew, this is not supposed to wheel people out and say, look, this is the story, and this is the story about leronlimab. It's bigger than drugs. It's bigger than medications. This is a perspective that we don't ever hear about.
It is. Cautionary tales, and people need to learn how to navigate the healthcare system, because even when you know how to do it, it still is very treacherous.
I do want to thank all the hardworking doctors and nurses that took wonderful care of you, of my husband.
And now,
OT, PT.
I mean, they did. We were in uncharted territory. We were early on in the process. Nobody knew anything, but look at this. He was,
yeah.
I mean, seriously,
Yeah, it's amazing.
he beat the odds.
Yeah, well, it's amazing, and he set a record, longest COVID patient in the ICU to be sitting here talking to us.
And newlywed.
Oh, congratulations! Well, that's cool. So
He's choked up about that. You can see it.
Yeah.
I really thank you guys for coming in today and
No, thanks
again
for having
and
us.
sharing the story. And I kind of feel I'm watching our chat stream to see if people have any questions, for themselves. One of the, people are worrying about cost of this sort of thing. It's why you have to have catastrophic coverage, because when the catastrophes occur, you need it covered, because it goes on and on and on and on. And you have to be able to get all that care to have a full recovery. That's it. That's where it goes.
Yeah.
Okay, guys, thank you so much. And congratulations on your nuptials.
Thank you.
No, thank you. Thank you so much.
Okay, bye-bye.
Thank you.
Ron,
now-
thanks.
We're going to
Thanks,
take a little
Ron.
break.
Bye.
All right, we'll take a little break, and then we're going to bring Samantha Mottet in, who's got another hair-raising story. And Dr. Yogendra, I'm going to have you introduce her after the break, all right? All right. The World Health Organization estimates that each year approximately 1 million people take their own life. That's one death every 40 seconds. Experts predicted numbers would peak in 2020, but no one could have imagined the devastation brought on by COVID-19. During the coronavirus pandemic, you may experience anxiety, sadness, and loneliness. Existing mental health conditions, including severe anxiety and major depression, may worsen. If you're feeling hopeless, contemplating self-harm, or you're concerned about someone else, I'm here to tell you there is hope. A Mission for Michael is dedicated to helping clients achieve complete inner and outer transformation. Mission for Michael is the premier resource for intensive mental health treatment in Southern California. With an astonishing 2-to-1 client-to-staff ratio, each client in their facility receives individual care 24 hours a day, overseen by a team of all doctorate or master's level clinicians. With a focus on evidence-based treatment, along with personalized and compassionate care, they offer mental health treatment that can change lives. If you're suffering from mental illness or you're concerned about a loved one, go to amfmtreatment.com. Again, that's a Mission for Michael, amfmtreatment.com, or call 866-581-4401. Again, that is 866-581-4401. All right, we are back again. Thank you. I'm looking at the thread. People are talking about the coverage of healthcare. Look, anybody can afford catastrophic coverage. Don't mistake good medical insurance for catastrophic coverage. Catastrophic coverage, you're going to have to spend a lot of money. Like you have a deductible, right? And if you make that deductible $10,000, that's a lot of money. But the catastrophic cost could be millions of dollars. So covering catastrophic care, make sure whatever you do with your healthcare coverage that it includes don't worry so much about the early stuff, because none of us spend that much money unless we have chronic illnesses in the early stages. But it's the latter part of the costs that become ridiculous, and you've got to have your insurances cover that. And insurances that cover that are usually very affordable. So, Dr. Yo, are you still with me?
It took me a minute. Dr. Purcell wasn't leaving. Sorry, it took me a while.
So you know what I'm talking about? People, this is a whole other conversation about how to get proper coverage for what your particular needs are. It's complicated.
That was a story that I was tearing up.
That's a crazy story.
So he never had I can't say it.
He didn't get leronlimab.
No, okay.
He was not able to get leronlimab. We came right to the finish line. I think maybe if we had another day or two to really sort that exclusion criteria out, hammer it out a little bit, I think he would have gotten leronlimab.
All right, let's go ahead and introduce Mrs. Mottet right now. Can we do that? Samantha Mottet.
She's there.
Is it Mott or Moffitt?
I hope she's still there.
It says Mott on the board here. Am I getting that?
Mott?
Mott?
I think it's Motte.
Motte. Okay. I'm getting it wrong all the way around. Samantha, welcome.
Hopefully we can hear her.
Thank you.
And I'm going to have Dr. Yo describe your case.
Okay.
So, Yeah, Samantha Motte, who I had never met before, never spoke to her. I read her story in April and read about her care from Dr. Yang, Dr. Otto Yang's infectious disease at UCLA. I was on some email chains with Cytidine, just trying to get some information about leronlimab for Tom, and got in contact with Dr. Yang in these email chains. I've seen a lot of his presentations about not just leronlimab, but just the clinical trials that he's doing, him and the other incredible doctors at UCLA that are doing. And it's interesting because we've got sort of two stories here, where Dr. Purcell's story was in a small community hospital in Florida. A lot of us don't know about EINDs and experimental drugs, versus a big, large teaching institution that has obviously much more money, resources, and information.
It's a research hospital, not just teaching, but they do this sort of thing there a lot.
Absolutely. So, it's interesting just hearing what Dr. Yang had to talk about leronlimab. And just over the last couple of weeks and months, Samantha's story has been talked about extensively all throughout media. She is sort of the face of, I think some people will call me the social media face of leronlimab. Well, she is the public face of leronlimab. Her story I've shared with many other physicians. I shared with Tom's doctor in the ICU, and it's anecdotal. We don't have, at the time, we didn't have really any studies. It was Dr. Patterson's paper hadn't even come out yet, or even the preprint. So we really didn't have a lot of information going on. But at the same time, people ask me about other medications. Leronlimab was really the only one that was talked about. Probably in the last 2-3 months, we're starting to hear about all the linzulumab and aviptidils and itolizumabs. So we're really talking about April now. Would things be different now? Possibly. We could look at other experimental drugs. Samantha was, if I'm not mistaken, the first person in the West Coast to get leronlimab. They were trialing it at the Montefiore Hospital. Dr. Patterson had discovered that leronlimab could have an effect on COVID-19. And that's how I, probably about 2 weeks ago, I had Samantha on my show. And probably in the last 2 weeks, we've gotten to be pretty good friends too, not talking about COVID, but some of our other things. And she's got a really incredible story to share with us.
Samantha?
Hello.
Hey there. So you got sick when?
March 17th, St. Patrick's Day.
And tell us the story.
My story is really March 17th. I'm not for sure where I was that day, but I just felt really tired, and I came home and got in bed, and I did really not get out of bed until the following Sunday. I had called my transplant team. I'm a liver transplant of 14 and a half years, because I was concerned about my liver. I'd been really tired. And I think it's interesting, earlier you talked about encephalopathy, and I think that's what I had. I had that before I had my liver transplant, but I've been talking about how tired I was, and you really brought to my attention, I was suffering encephalopathy before. But I called my transplant team, and they had lowered my mycophenolate a little bit. And then by Sunday, March 22nd, just what I had left in me, I had my husband call UCLA. I didn't even have the energy to call UCLA, my transplant team, and see if I said, I need to go to the hospital. And I went to the hospital. I was there about 4 hours. They rehydrated me. I had a chest x-ray. They said I didn't have pneumonia. They said it's best for you to go home because we have COVID-19 patients and you'll be safer there. But they did check me for the COVID-19, and they called the next day and I had it. And I did not check into UCLA until Friday. I did a couple of FaceTimes with my doctors. And then when I was checked in the morning of March 27th, I was put on the little nose oxygen. By Saturday, I was on a full mask, and Sunday at 1:00 p.m., I was put on the ventilator and a feeding tube. And I got my notes. I talked to Dr. Yang last week, so I got a little more information. On March 27th, the day that I entered UCLA, and the next day, I was giving
Hydroxychloroquine?
Yes.
Yeah.
And on the 29th, the day I was put on the ventilator, I was giving the toxilumab.
Oh, really?
for 80
Taxilo-
milligrams.
Yeah.
And then also the placebo. And so by Saturday night, UCLA had called the doctors had called my family and said, she's not doing well. We're going to have to put her on the ventilator tomorrow. And then by Wednesday, I'm not for sure what time of day, but they said she's really taken a turn for the worst. And that's when Dr. Yang came in with the leronlimab. And it was administered on April 2nd at 4:30 p.m. And while I was waiting on April 2nd, I did very well. My ALT was 18, my AST was 16, my white blood count 6 point, my kidney was 0.7.
I'm gonna stop you. So the white count, Dr. Yo, must have been reassuring to them, specific more than anything else, really. And the fact that she's going in the right direction too.
And also, you know what sort of the curveball in all of this is she's already on immunosuppressants for the liver transplant.
I know. I don't know what to make of that, right?
So Samantha and I, when we started talking, I said, this is not a very straightforward case. I actually called her, I think you're like an outlier. And she goes, what do you mean an outlier? I said, well, you got this, your immune system is all modulated right now with the suppressants. So really hard to
you
say.
said the mycophenolate. What else are you taking?
Well, on March 27th, the day I entered the hospital, they stopped the mycophenolate. And I was on 1 milligram of tacrolimus twice a day and 5 milligrams of prednisone. They never increased my prednisone during my hospital stay.
Which is interesting. Kind of interesting just by itself. I would have given her stress steroids just to cover chronic prednisone, right? And it's weird that they didn't do that, but okay. It worked out fine. So now you're getting better. Your white count is up.
I'm giving the leronlimab on April the 2nd. And the reason I know these dates so well is April the 2nd is my brother's birthday. And so I'm completely out. They had put me in an induced coma on March 29th, and the next day I popped out of it. And then I was really out for a good couple of days. From April 2nd to the 4th, I woke up a little bit just because I know some of this stuff just because I read back on my text messages. I know that I was alert and aware, but I don't remember it. And then on my 55th birthday, April 5th, at 12:30 p.m., I was taken off the ventilator. So from the time that I was administered to leronlimab until they took me off the ventilator, it was like 68 hours.
Wow. Dr. Yo, what do you think of her case?
Yeah, it's obviously it's very hard we can't ever say it's conclusively leronlimab.
Right.
It's a little, potentially it could have, but she got hydroxychloroquine, she got tocilizumab. Did they have an effect before? And also with her immunosuppressant, that really throws the picture. It really just muddies the picture up a little bit. It's not a big clear cut. But what's interesting is Dr. Patterson has talked about day 3 being he's actually said the magic day 3, or day 3's magic. I think those are his exact words.
Mean the third day of leronlimab?
The third day after being administered leronlimab is when you start to see those immunomodulating effects of leronlimab. You start to see the decrease in the viral load, which he's shown in his Montefiore paper. So there's something very interesting that Samantha's talked about with day 3, or that 68 hours, and what Dr. Patterson is seeing immunologically and virology. And, one of the things, Dr. Patterson, I was having a discussion with someone about this, said, well, he said that it works. And I said, yes, it works immunologically, virology, looking at the serum, but we have to align it clinically. And not everyone might respond to leronlimab in the sense that, yes, they bring their viral load down, they bring the cytokines down, but clinically they may not improve because we can't look at this in a vacuum. And I think sometimes, not everyone is going to respond to these medications. I think that's almost a very important point I try to tell everyone. The thing I always say is, tell me which is the best hypertensive medication, enalapril or Norvasc. And and my point is everyone responds to things, and that's where we have different tools in the toolbox to throw at people. But with Samantha's case, it's suggestive, but I don't think any of us can say it's 100% conclusive.
So there's an interesting thing going on in the chat thread, which is somebody saying, well, now wait a minute, do you have IL-6 inhibitors that withstood randomized clinical control trials, which we don't have yet, do we?
I'm not, so I think they're probably referring to tocilizumab.
Yeah.
I believe that was, there's been a trial, Roche is the pharmaceutical, and I believe they've shown that it's not effective. This was about
and that was, how many patients were in that trial, do we know?
I don't remember off the top of my head. This was about 2 or 3 weeks ago. I can look it up.
Does that mean it's not being used anymore, or does that mean that we're still using it, waiting for a bigger study or more replications? I mean, this is the way medical science goes. We do stuff until the studies catch up with what we're doing.
Yeah, and talking to ICU doctors around the country, I think even before that study came out, I think it's been, we haven't really been using tocilizumab.
So it's going down in terms of use. All right.
Right. I think the initial thought was that was the quarterback, IL-6, but there might be some other players now.
Got it. And the hydroxychloroquine obviously is the other big thing that we still don't have the data on that yet. And that I see people using it widely to this date because no downside. I mean, hydroxychloroquine is totally benign. Are we going to ever get the right studies on that?
Big question. You know, but interestingly enough, I think about yesterday or the day before, there was a study that just came out suggesting that CCR5, then that's that main receptor in rantes, right? Is actually, there was a computer study, and they also looked at some lung biopsies also in this journal article, suggesting that in rheumatoid arthritis, you're seeing CCR5 upregulation in the T cells and T helper 1 cells, which now kind of ties into the rantes that CCR5, CCL5 axis possibly playing a role in rheumatoid arthritis. Mm-hmm. And what's interesting enough is we obviously use hydroxychloroquine. It's one of the DMARD medications for rheumatoid arthritis. And there's some suggestion that hydroxychloroquine actually has some immunomodulating factors. It changes the conformation of some of the cytokines. Mm. So that could be potentially a possible treatment for long haulers. Sort of this light bulb went off in my head. I sent it to Dr. Patterson, said, this might be something for our project that we're doing. So
he's using leronlimab for long haulers, right?
No, I mean, it's not approved yet. In fact,
no, but I mean, he wants to study that. Isn't that what he wants to do?
Yeah, so we're actually doing a joint project. We're probably going to unveil this in a couple of weeks, where we're looking at our goal is then he has a partnership with MD Bioscience, where people can with requisitions send their labs in, and it's almost very targeted therapy where we'll run cytokine profiles and targeted therapies based on it. So someone, let's say with elevated rantes, could theoretically get treated with leronlimab. But not everyone has elevated rantes. Some are having elevated TNF. Some have elevated IL-6. So it's a very mixed cytokine profile in these long haulers. And that's what we've seen in a couple of patients. We're planning on putting out a couple of case reports on this. The other interesting point, and this is very reassuring, is that the T cell exhaustion, we've talked a lot about how the T cell gets depleted or exhausted in COVID-19, it actually is resolved. It's back to normal levels when compared to the controls in the long haulers we're studying. So that's a very promising and encouraging result we're seeing.
Yeah, I'm just making a note here because for the internal medicine, we have to do this test called the MKSAP, where we have to constantly take these updated exams. And people are on the thread talking about hydroxychloroquine being so unsafe. I have 1,000 pills out there with my name on it, 35 years of prescribing, never seen one side effect. And the MKSAP is recommending hydroxychloroquine continue during pregnancy. It's the only medication I've ever, they were adamant that if you have lupus and pregnant, you keep them on the hydroxychloroquine because it is, literally, this is the recommendation of the MKSAP. It is so safe, leave them on, don't even think about it. So the idea that hydroxychloroquine, not chloroquine has a bunch of side effects for sure. Hydroxychloroquine, never seen a single side effect. And by the way, I've interviewed a number of ophthalmologists that have never even seen the one known side effect, which is ophthalmological. So let's go back to Samantha. So Samantha, there we are, and you made it out. Did you have any long hauler symptoms yourself?
I did not.
And how long did it take to kind of recover fully?
I would say between 3 and 4 weeks.
It's pretty
And
good,
by that
right?
time, I was pretty much back to normal.
What would you, do you have anything from the patient perspective to say about the experience that you want people to know?
It was really, really awful.
Yeah.
As you may know, being a liver transplant, you go through a lot just to get on the list. Then afterwards, until you get your liver transplant, it's a lot. It's the worst thing that I've ever gone through. It's horrible. I would never want to go through that again.
And this is from a transplant patient's perspective.
Yes.
That is saying something, as they say.
When I compare the two, my liver transplant was a piece of cake compared to having the coronavirus.
That is saying a lot.
And Dr.
Yeah. Dr. Yo.
I was just going to add, Dr. Drew, was interesting, talking to Samantha, was there were parts of her ICU stay that she was actually awake. She's got pictures on her phone and text messages. So we were talking earlier about with Dr. Purcell and how he really has no recollection. He doesn't have any recollection of that FaceTime conversation I had with him. He said, I had no idea. In fact, I was the one that broke the news to him after he got recovered that he had a cardiac arrest, and he was bawling on the phone. I felt horrible. I thought maybe someone told him. And here's Samantha. So, she has some recollection in the ICU, which can be just as scary when you're in isolation, you're awake. I don't know, maybe Samantha, you can just talk a little bit about that. You're alone. Your kids are in New York.
Oh,
how did
wow.
that feel?
Oh, boy.
Luckily, I had FaceTime. I had my phones with me, and that was a big help for me. But really from March 17th until April the 5th, when I had the ventilator out, I don't remember a whole lot. There's just bits and pieces. But after the ventilator came out is when I really went into the hallucination state for a couple of days. When they took the ventilator out, I thought they were taking me off life support. I was dying. I went to go to another hospital. I felt UCLA was killing me, which I know better. They've saved my life twice now, but it's a scary state to be hallucinating and you don't know what's right and what's not right. And I really appreciate the nurses who took care of me because I was not a good patient at that time.
They're used to ICU psychosis, trust me.
Yes.
You look so well right now. You don't have to answer this question, but I'm just curious what your underlying liver disease was.
Pardon me?
You look so great. You look so healthy. And I'm saying you don't have to answer this question, but it makes me curious about what your underlying liver condition was.
When I was 5 years old, I got hepatitis. My body had attacked my own body. Luckily, I didn't have.
You have what's called lupus hepatitis or lupoid hepatitis.
What really Dr. Goldstein.
Autoimmune
disease is what Dr. Goldstein called it at
we
UCLA.
used to call it lupus or lupoid hepatitis. It's autoimmune hepatitis, which is unusual.
I hadn't heard that, but I was in Riley's Children's Hospital in Indianapolis. Dr. Joseph Fitzgerald was my doctor, who just recently retired, actually. And then I did very well with my liver up until I was 30 years old. I had my third child. And I started having things go wrong, which Dr. Fitzgerald had told my family when I was a young child that, and by the time I'm 40, that I might start seeing some issues with my liver. And sure enough, at 40 is when I had my liver transplant. So really my whole 30s, I was slowly in a decline. I've been affiliated with UCLA since I was 28 years old. And I've done very well. I should say. I've taken good care of myself.
Even in the setting of a dangerous illness, your liver performed.
Yes, it did.
Yeah. Dr. Yo, anything else you want to have Samantha tell us?
Yeah, Samantha, if you can just also share with us, I talked a little bit about Dr. Yang and Dr. Kadir was your pulmonologist at UCLA, and I've never met these doctors. I've been following their research, just incredible. I have so much respect. Can you just talk a little bit about their approach? And, one of the big questions everyone has is, how did Dr. Yang know about leronlimab? Because most of us didn't know. We don't know about how to get these emergency drugs. How did they know that? I mean, obviously they're teaching in a research institution, but I think you described to me that this was a Hail Mary. Can you just talk a little bit about that the decision making and how you got leronlimab?
Well, my family, and Dr. Yang even told me this himself, that on Wednesday, April the 1st, they stood around as doctors and felt like I wasn't going to make it. And they was just wondering what is the last thing. And I think not him in that circle, Bart, but they went to Dr. Yang to see if there was anything left, if he had anything in his back pocket to help me. And he came up with the leronlimab. And he's been dealing with the leronlimab. I can't put words in his mouth, but this is what I'm assuming, for a long time, because he does a lot of HIV research. So he knows about the leronlimab. And that's why he brought it into the picture. So and I think he'd also heard about it being used on the East Coast as well.
It came in through the HIV world, I'm sure. That makes perfect sense, because UCLA, Los Angeles has always been right at the forefront of all the cutting edge therapies in HIV. So that kind of makes sense to me. Do you think that's it, Dr. Yo?
Yeah, I think so. I think Dr. Yang is, ever since this, I've been following his other research, and I'm assuming that it's probably the HIV connection. And it's been studied extensively in HIV, which again, I didn't really know. I didn't know about leronlimab. I'm in the anesthesia and critical care world, not looking at HIV medication. So, but there's some quite interesting data. There's over, I think, 800, 900 patients in their trials, and shown some promise. And I think they're trying to get some sort of FDA, BLA approval and get that approved. So something to look out for in the next couple of months.
Yeah, we need a menu of options. We need to develop some judgment with the application of these different medication, and that's going to take a while. And I still believe that sepsis and septicemia is going to get changed. The approach is going to be different. Samantha, I'm going to let you go. Dr. Yo and I are going to geek out about a couple things for a few minutes, but we'd really do. It's lovely to see you thriving and looking so well. I mean, you do not look like a liver patient, and you do not look like somebody who just survived a near-death experience. So that's very.
She doesn't look 55. According to our
it's actually 5 months ago today that I got out of the hospital, so it has been a good 5 months. It's not like I got out yesterday. It has been 5 months.
I get it, but liver patients can look. You can see it oftentimes, and I cannot see it on you. So it's great. And thank you for sharing the story. And please do keep telling people about it, because I think it's an important story to tell.
I will. Thank you so much for having me on your show today.
Thank you so much.
Thank you.
Thanks, Samantha.
All right.
Thank you.
Ram, we need to do a little Bradykinin talk.
Yes.
Okay. We need to, because I don't understand how that hooks in with the overall Ranty story, and you're going to educate me on that. And there was one other thing I wanted to get into. It dropped out of my consciousness right now, but I'll think of it in a second. Let's start with the Bradykinin.
Yeah, the Bradykinin theory is very interesting. Actually, early on today, I spoke with Dr. Daniel Jacobson. He's the chief scientist of computational biology at the Oak Ridge National Lab, to discuss his manuscript. I always say, sure, I could give you my assessment. We can talk amongst ourselves. Let's get the big honcho in here.
Let's
source.
Exactly. Go to the source. Yeah.
So it was an incredible discussion with him. Very interesting. I'll just quickly touch upon the Bradykinin. This is basic biology. We learned this, the general biology, undergrad, physiology in med school. The Bradykinin theory, what Dr. Jacobson, they used a supercomputer, but they actually took a bronchial alveolar lavage from real patients, did some genetic sequencing in the codes from the serum. And, I don't understand I'm not a mechanical computer whiz, but they put all this data into this supercomputer.
Yeah.
And they were able to identify that the genes that were upregulated were coded for Bradykinin.
In the setting of COVID or sepsis, or what are we looking at?
In the setting of COVID. Yeah.
Okay.
COVID
and the post-viral cytokine storm state.
This is, I'm not exactly sure. I think all these patients had either died or they were severe critical patients.
Okay, so severe COVID upregulation of bradykinin. Which, did they have a control group? I would think bradykinins would be up on all critically ill patients.
I didn't see. I think they compared it with normal patients.
Okay. All right.
To determine, right. So they didn't, because I asked him specifically if he looked at ARDS or septic patients, but they only looked at COVID and normal healthy controls.
Okay. That's sort of a weird control, but okay.
So, because I was very interested, I'll talk about a couple of interesting things they found. And what I'm interested to know more about So what they've found was the ACE receptor. So the renin-angiotensin system. We know that the juxtaglomerulus apparatus in the kidneys, low pressure, secretes renin. Renin goes. It has this whole cascade that's described in physiology books. But there's an enzyme in the lungs called ACE, and the ACE acts almost like it's like this sort of checkpoint. And what ACE does, it converts the angiotensin 1 enzyme to angiotensin 2. But what it also does, it causes the bradykinin to break or to cleave or to be deactivated. And that's what happens when you have those ACE inhibitors, which blocks the ACE enzyme. And what the ACE enzyme does is then we use it to treat hypertensive, because angiotensin, the enzyme that the ACE receptor breaks down, is actually a vasoconstrictor. So by inhibiting that, you're then reversing the vasoconstriction and treating the hypertension.
Right.
But what
my
the ACE
understanding is
enzyme,
the ARBs have an even more powerful effect on the bradykinin system.
well, they're
That's
working
what I
right
always
on.
thought.
Yeah, they're usually working on the receptor, the receptor blockers of angiotensin.
It particularly irbesartan has a very powerful. But it's a reason to choose irbesartan over other ones because of its effect on bradykinin. But go ahead.
Absolutely, and that's why when we give enalapril or the ACE inhibitors and patients develop the angioedema, it's just due to the bradykinin, will usually get switched over to the losartans or the ARBs. So it's very interesting how when you just look at take COVID out of the equation, just how we see the bradykinin when we give the ACE inhibitors, you're going to see an increase in the bradykinin, which causes arteriolar vasodilation and the what's called venoconstriction. So it squeezes the veins and it dilates the arteries. And that's also one of the vasodilatory effects of these ACE inhibitors. But bradykinin also can cause patients to cough, because there's also dilation of the pulmonary vasculature, which is something we see with ACE inhibitors. So what Dr. Jacobson has determined...
And people are asking, let me just say on the thread, ACE inhibitors and ARBs do not put you at added risk of COVID. In fact, there was a brief period where we thought it actually protects you against COVID. The current guidance is don't change your ACE inhibitors, don't change your ARB. It doesn't seem to make a difference.
The European Society of Cardiology came out with a statement about 3 months ago suggesting that very same thing, that not to stop your ACE inhibitors for that. So that's also in the medical, I guess, the community and society is also suggesting that too. There was a Lancet article that suggested that there might be might cause an upregulation of the ACE2 receptors, but the Lancet also said it's just merely a suggestion. We're just throwing it out there.
That was early. That was when we started really looking at all this, and it just didn't bear out clinically. So,
absolutely. So going back to the bradykinin, it's very interesting. So you have elevated what the virus does. The mechanism of action that Dr. Jacobson's proposed is that the virus acts almost like an ACE inhibitor. So we said that the ACE inhibitor is going to increase the bradykinin. Yeah. The virus acts on this ACE receptor. The proposed mechanism is as an ACE inhibitor, thus causing an increase in the bradykinin.
Okay.
The other interesting thing that they found is, and I wasn't able to discern, and it hasn't been clearly described how this mechanism happens, but they found when they did the bronchial alveolar lavage on these patients, the alveoli of these patients had increased level of hyaluronic acid. And the proposed mechanism is bradykinin has some effect on increasing the hyaluronic acid in the alveoli of the lungs.
So that's maybe part of the ARDS picture?
Possibly, right. And so this was the question I had for Dr. Jacobson, and they're still investigating this, is when you take non-COVID ARDS versus COVID ARDS, and you're looking at fluid, is there a difference in the fluid from ARDS versus this hyaluronic acid buildup in the alveoli of these patients? So he almost described as like putting a hydrogel, I think he used this exact word in his manuscript, a hydrogel in this alveoli. Thus, you're preventing problems with gas exchange. And he's theorizing this is why we had problems ventilating patients that were on a ventilator.
People are asking some good questions whether or not this vasodilatory effects have any issues with the blood-brain barrier. Not that I'm aware of.
Actually, in the paper, he's suggesting that the bradykinin actually does cause a which was interesting to me. I didn't realize this, but he's suspecting that some of the neurological sequelae from COVID-19 is due to the bradykinin, elevated bradykinin, causing some sort of cerebral edema or something with the vasculature.
This seems too just so to me. This does not feel nearly as compelling as the ranty story you were telling me last time. Mostly because we screw with the bradykinin system all the time in all kinds of different ways, and it doesn't have such devastating effects. Now, I understand the quantitatively this might be on a different level. It just doesn't.
Well, you know what's interesting, and I agree with you, Dr. Drew. You know, so here's the interesting thing: is the half-life of bradykinin is a couple of minutes. And this is going to be the problem studying bradykinin.
Yeah.
Is how do you measure bradykinin levels? You can't just draw someone's blood and measure. I mean, what do you compare it to? Is it at the peak? It's not like the ranties or the cytokines where you can diagnose. We can use it as a diagnostic tool.
Is there a connection between the ranty system and the bradykinin?
Yeah, that's a very interesting question. So there's some literature suggesting that the B2 receptor. So in all your tissues in your body, you have a bradykinin receptor. So when the bradykinin is released, it goes into these receptors all over your body. The bradykinin, the B2 receptor, and I have to make this very clear, there's beta 2 receptors and there's bradykinin receptors. When I'm saying B2 for this discussion,
not beta.
For the bradykinin.
Yeah.
The B2 receptor actually causes an upregulation of the CCR5 receptor. So
is that regulatory? Can that be pathological?
So the way I've interpreted it is that the bradykinin, when it binds to the B2 receptor, that it upregulates the CCR5, meaning there are more CCR5 available, meaning that there's more binding sites for ranties, thus worsening the inflammatory system. So there's some sort of linkage there.
Well, that makes sense. That makes sense. Again, that's the whole way. That's kind of the way that the inflammatory system works. It interacts in many ways, and it cascades. It's a cascade.
And there's been a lot of discussion. Oh, it's the bradykinin hypothesis, and the cytokine storm is not waning. I think there's an overlap. I think it's maybe possibly sequential. There's some overlap taking place, and we can't look at these things in a vacuum and say, this is it. It's cytokine storm or it's bradykinin storm, and it's a meshwork of pathways and whatnot.
Exactly. If you go look up cytokine pathways and immune modulation, you'll see it's a web. It's a giant web, and that's already a fantasy. You know what I mean? When we start telling ourselves stories about physiology, it's just that. It's stories where we tell ourselves to try to understand what's going on. Now I remember what it was I wanted to lay on top of this. So there's an interview I just got as the microphone started heating up here from Dr. Paul Offit, a famous vaccine researcher, right? And he is in this interview describes the post-viral syndrome that we're calling cytokine activation. He described it as vasculitis. And it sort of took me aback because we were calling it vasculitis at the very beginning when we kind of didn't know what was going on. Is there a vasculitic component to this? I know the endothelium figures into how it cascades and part of the inflammatory process, but technically, is it a vasculitis?
Is in regards to the long haulers? Or
no, the cytokine storm.
Cytokine storm, absolutely.
It is a vasculitis technically.
I think it's a component of it. I wouldn't call it only a vasculitis.
And the reason I ask is, vasculitis has a whole world of treatment to it that we're not talking about. Cytotoxic and all kinds of treatments that we use for bona fide vasculitis. And if this is truly a vasculitis, why aren't we talking about those things?
Well, if you look at the mechanism of action, ranties is found in the endothelial and epithelial cells. So, and bradykinin, the bradykinin is activated, or the factor 12 is playing a role in the bradykinin system, which is
Right.
part of the intrinsic system of the coagulation pathway. So you can tie in both the bradykinin and the RANTES and even some of the other cytokines as playing a role in possibly vasculitis. But I don't know if you would call it just solely a vasculitis. That just seems a very
You have to see the vasculitis is a pathological thing. You have to see and it can occur in different places in the microvascular system. And I haven't heard anybody really talk about that. It's just surprising to me. It's just another area to kind of think about if that's true.
It could also be possibly, obviously, there's vasculature in the organs, and we might actually be seeing some of the damage in the, let's say, the pulmonary vasculature or the
Right.
liver vasculature, or the renal vasculature. So there might be on a much more granular, deeper level, right?
Huh. Again,
But
that's food for thought.
But when you look at the pathology reports, you're seeing the ACE2 receptors being expressed everywhere. So all over these the organs. So it's one of those things where I think of multiple things are going on, and I can't as we've talked about before, Dr. Drew. It's not about this is a cytokine storm and viruses are not involved. I think there's definitely some overlap. I think the ACE2 with the virus, the cytokines, all these players are all involved.
I'm getting confused again. I was so clear. I had such clarity after I talked to Dr. Patterson. but that's how it works. I mean, that's how my thinking moves forward. I always go into a bit of a fog, and then I come out on the other side with some more clarity.
Yeah, I think that's what medicine is. There are no absolute truths. When you think you've got something solved, it's something. Another paper, another research comes. There's a new study suggesting that the cytokines, the elevated cytokines that we're talking about, the cytokine storm in COVID-19, may not be elevated now. And so, right, they're suggesting maybe the cytokine storm might be, it may not be as prominent as we thought it was. That's what Dr. Jacobson also suggested today he's not seeing an elevated cytokines as that's what Dr. Patterson is seeing in the lab. Which goes back to, I think the point is that everyone responds differently. Everyone clinically is responding. I don't think, and going back to some of these therapeutics, not everyone's going to respond to everything.
Right.
The more patients we have, there are many different clinical presentations. In the case of, we were talking about Samantha, she's on immunosuppressants. I mean, that just completely changes the way we're looking at her lab work. How did that have some effect with leronlimab?
How do we even understand her immune function in the setting of something like this? It's wild, right? Even though they'd taken her off stuff, it's still like, woof. Yeah, and I really am curious why they didn't give her stress doses of steroids. I mean, she's on chronic prednisone, and they did not give her stress steroid while she was in shock. I've seen that before. I've seen that missed many times before.
Yeah, it happened to me.
Happened to my wife. She almost died because of it. I had to run in there and go, she's on steroids, but put her on stress steroids. She just lost 3. After she delivered triplets, she went into shock. And I said, just unloaded 3 circulatory systems. What do you think is happening here?
I was on
and I do that all the time in the operating room. I have someone on chronic.
But anesthesiologists are really good about it, and then it doesn't get continued outside the operating room. I see that all the time. But anyway, who am I to say? Another little observation about the healthcare system.
But I lived.
Damn, we tried to kill her off right back there at the beginning. But it is this whole conversation, and as we bring up new topics, is the humility with which you have to approach any biological system. Biological systems are like, again, they're not like bridges. They're not like this. They're not like a cell phone. They're closer to like clouds or climate. Climate's another good one. It is extremely difficult to nail everything down and we just sort of understand. We do the best we can to kind of understand what's going on and kind of change the physiology as we understand it. Agreed?
Yeah, absolutely. I agreed, Dr. Drew. It's very interesting just talking about anesthesia. I tell this to my patients. We actually don't know how these drugs work. It's all on frog, and we open up my Miller and
Yeah.
my Barish.
No, all those gases you guys use, we have no idea how those.
I have no
work.
idea.
That's
And
why-
the
that's
patient's
why-
like, what do you?
I know. I can tell you, it doesn't go well with me. I'm shitty for 6 months after anesthesia. So thank you for that. But I don't wake up.
Well, there we go. It's about keeping you asleep. We don't care once you're out of the hospital. No, I'm kidding about that. But yeah, we know there's nothing like very clear cut. I think some of we're in medicine and we recognize that it's not that things are not black and white. There's a lot of overlap, a lot of gray, a lot of different clinical presentation. So that's what we're clinicians. We're not technicians.
That's right.
We are able to respond to these things.
And I'm convinced I have whatever this sort of cytokine, whatever we're going to find out this thing is that let's keep calling it cytokine storm or activation. I'm prone to that. Because I had H1N1, I was so toxic, and I knew that was terrible. And I'm thinking back now, I had a severe Epstein-Barr when I was 17, and had splenomegaly and really went south. And I remember my dad took me to some specialist, and they put me on Decadron for a couple of days, and I turned around instantly. Isn't that interesting? That way back there, somebody had a hunch that something like this was going on in bad what should we call it? Post-viral inflammatory conditions.
Mm-hmm. Yeah, it's funny. So I would say probably steroids. Decadron might be the magic pill. If you're not sure, hey, just get some steroids, see if the patient responds.
Hey, listen, the COVID patients I had given steroids to did very well. And I gave it to them because I wasn't sure it was COVID, and there are people that got recurrent pneumonias who I'm always using steroids and antibiotics on to get them through their pneumonias, got through the COVID rather well. Interesting.
And, just to echo what you said, Dr. Drew, Dr. Richard Bartlett is, I believe an emergency room doctor in Texas, and he's been using budesonide, inhaled steroids, and he's saying he's having incredible results.
Yeah, I don't know if I believe that story. Let's, because here's why I don't believe it. It doesn't make sense to me, number one, so I'm already skeptical. But number two, unless you're seeing elderly patients with multiple risk factors, everybody gets well anyway. And I think people forget that. Right?
Yeah, if you look at the data, it's I think it starts after about 55 is when the increase in risk. I think at 80 is when I think it's like 22 or 23% mortality. So you're absolutely right. Yeah, the underlying conditions, the numbers are just so low.
So as we wrap up here, I want to do just our last few minutes on case fatality rate versus infection, all the different fatality rates that are getting all conflated right now. And by the way, let me do 2 seconds on case rates. The fact that we identify as a case, just the presence of a fragment of viral RNA is enough to call somebody a case. That's going to start to become a problem, because cases should be broken down into sick, infected plus infectious, or just viral RNA present, because those are different things. And the fact that we lump those things all together now is very problematic.
Yeah, and I think that's you're absolutely right, Dr. Drew. I agree, because we're seeing even the PCR tests, which were quote unquote the gold standard. There's so much of error in those tests, and because they're picking up those viral particles.
Exactly. Which is everywhere now. And we're going to have it. It's going to be with us forever, because not everyone's going to get vaccinated. There's still going to be some COVID around for a long time, and you'll be able to pick up the viral pieces because our tests are we do 40 amplifications on our PCRs. We're going to find pieces. But anyway, tell us about the case fatality rate issue.
Yeah, that's a very interesting. I think it's Dr. Brown from University of Waterloo in Canada. So we're going to just dive into a little epidemiology. So you've got really mortality rate, case fatality rate, and infection rate, or infection mortality rate, and really understanding, and really understanding infection fatality rate. Right? Yeah. All of these words can get a little tongue twister. So it's just really important when people are trying to read and trying to understand what each of this means. Mortality rate really looks at, let's say you have 100 people in the population, and let's say 10 or one person has the infection or has the disease, one person dies from that disease, the mortality is then 1%. Mm-hmm. When we're looking at case fatality rate, those are the number of people that, let's say, that have the disease. So if you have 100 people in the population, let's say you have 20 people with the case, with the disease, and let's say one person dies, then you're going to say the case fatality rate is one out of 20, it's going to be 5%. Now, the case fatality rate really looks at the severity of the disease. Those are people that have the disease and how many of them are going to die. So really looking at how severe it is. Infection fatality rate is a little bit more, in my opinion, can be a little bit difficult to identify, because your infection rate, you can have the case can be an infection. An infection cannot be a case.
Right.
Because and that's what
you're getting in the same data that I'm. It confuses us on the fatality side, and it confuses us on the case rates, whatever that might mean.
Absolutely.
It gets very, and we're reporting all things and conflating all things. So as this goes on, we're going to have to parse out. And by the way, Andrew Ashkasvili, who's one of our good supporters here on the chat, reminded me that Michael Levitt tweeted today that he looks at excess mortality, period, relative to baseline mortality. And we're right now 14% are below baseline mortality for all the last several years. Not only are we're not above, we're below what numbers of people that normally die per week right now. It's crazy.
Yeah, and it goes to show you how you can manipulate data if you don't understand what it means. I mean, that infection fatality is really looking at people that not only tested positive, you're talking about the asymptomatics, and also people that are infected but have never been tested. So you have to include that into that infection rate, and that's why you look at the infection fatality rate of seasonal influenza is like 0.1%. And I think this paper they were suggesting they were trying to compare that with the case fatality rate and inflate the COVID numbers to kind of make it seem like it was tenfold or. Yeah. So again, it's a play on words, and if you don't understand what is what. Well, the interesting thing about that paper from Dr. Brown, a colleague of mine actually pointed this out to me, that Dr. Brown talked about the H1N1 influenza outbreak. That's not a seasonal influenza.
No, that was a pandemic.
If I had, and I went back and I read it, and that was probably a valid criticism. It's almost like he's cherry picking the most severe influenza cases to make his comparison. But the overall arc of his paper, I agree in that if you don't understand what these rates are, then it's very easy to fall into the trap of interpreting it, making errors.
Exactly. So be very cautious about what you see in the press. Be very cautious about headlines. Really look into things, parse things out, make sure you understand the terms they're using. Look them up if you want to understand things better. I have to go do a television show right now. I do this local news broadcast on local Fox network. So there it is with Alex Michelson. We've been doing it since the fog of war, since this outbreak first occurred. And we've been sort of keeping people up to date on the local stuff here in Los Angeles and Southern California as it pertains to, we don't get nearly into the medical material as you and I do. And I appreciate the opportunity to do it. It massages my, I keep having these dreams that I'm not keeping up enough on academic material, and it really helps me feel better when I talk to you. I feel like you're my own private academic coach.
Well, Dr. Drew, there's so much information, even for me, I learn a lot from, your tweets, things you're posting. It's a community. We all learn from each other.
Yeah, that's right.
I don't think it's so humbling as we talked about how medicine and science is just, there's so much. People come and say, oh, you know so much about COVID. I feel like I know a fraction of this, and what I know today, tomorrow is going to change.
Right. So what you get is, the world is full of something called the Dunning-Kruger phenomenon, which is when you're learning a topic, the first thing you feel is, oh, I know so much about this. And then you quickly go into, oh, I don't know shit. And then as you come out and actually do start knowing a lot, you feel like an imposter. You feel like that's exactly what you described. Like there's too much to know. I don't know anything. And that's the stage I feel like I'm in all the time, where I'm like, it's not possible to get it all in. I know there's more. I know there's more. I got just around the corner where you and I are going to figure this out, Ram.
I always say, I don't ever actually consider myself a smart person. I'm an average person, but I like talking to really smart people and seeing all the smart thing and intelligent things that they're doing. And I just try to make a little connection and bring people together. That's
well,
sort of
you do
my
a great
role.
job of processing it and remembering it and putting it together in ways that are smart, let's face it. And again, you can follow Dr. Yo at Yo Dr. Yo, and the podcast again.
So I have my YouTube channel is also Yo Dr. Yo, which I talk a lot about health and fitness and medical topics and interview patients. That's sort of been going to be my next big thing for the next couple of weeks. I'm really highlighting families that are what they're going through, giving them a platform. I think I feel like we're going to face another pandemic or something close to this in some point in our life.
Well, unfortunately, random events segregate non-randomly. They come in series. That's just the way things happen. So you might, hopefully, we'll see.
Well, I'm not leaving.
Hopefully I'm wrong, but I want to be able to say, what can we do? It's the science is great, the stories are great, but and that's why, Dr. Drew, you're someone that we're going to look up to. I'm going to look up to. You've been in medicine for such a long time that we're going to look to you, someone like you, as a leader in saying, what are the changes? What are things we have to do to change our healthcare, our public health, the way we're getting information out? So again, I appreciate you having me and allowing me to bring guests on and talk to science and nerd it out.
Well, thank you. I like geeking out too. And it's just when you say things like that, I've got a million notes of how we can make it better, but I get overwhelmed when I think about how we make it happen. And then I think about how this whole thing got politicized. From the beginning, I kept saying, just listen to Fauci. He knows how to lead us through this thing. We don't need all these other opinions. He's conservative, and he's maybe a little too conservative for some people's taste, but he'll get us through this safely. He knows what he's doing. Instead, look what we ended up with all these ridiculous voices and politicizing, and then people not understanding what to trust and what not to trust. It really was very, very sad, in my opinion. And then the actual practice of medicine was affected by it. The other thing I would say, I would leave with two other thoughts. Again, a lot of what we talked about here today is a case for primary care, really high quality primary care, not just perfunctory primary care, real ombudsman, high quality, thoughtful care, which is what you gave your buddy, Tom, whether you know it or not. I mean, it was a little bit specialized, but it was just doing what primary care does. And then everyone's got to have catastrophic coverage. Everyone. How we do that, I'm not sure, but we have to do that.
Right.
Anything else to add to that, Ron, before I let you go?
No, Dr. Drew, I'm always excited to talk to you.
All right, man. We'll talk about that soon. Pleasure to talk to you. Good luck with everything, and we'll talk soon.
Sounds good. Thank you.
Thank you, everybody. We'll see you tomorrow, Susan, at noon. Is that correct? That's what's on my schedule.
I don't know. What do you want to do?
Noon.
We never got to that tweet that guy gave us, but that's okay. You guys,
let's do it tomorrow.
You guys had so much.
Yeah, we had a lot to talk about.
And everybody was really enjoying it on the restream.
Joanne, I see you there. I hope that helped. I know what you've been through with this disease, so maybe give you some understanding of what this was all about. And again, I was watching the chat. I appreciate you guys. Very lively interaction. Really some smart comment here, and I wish I could address all of it, but maybe we'll try to do a call-in show with Dr. Yo at some point near future. Mm-hmm. And I would like to try to get in here at noon-ish tomorrow, if that works okay.
Is that what you want to do?
That's what I want to do. Okay? We'll see you then.
Thank you.
Bye.
Real talk.
Headlines have become sickening. They become poisonous.
Dissecting headlines.
Defying state orders. Sheriff Bianco not enforcing what the governor is saying.
Dialed in with decision makers.
Clarify what you actually meant.
Get the answers you need.
At the beginning of this, we were told, don't wear a mask. Is this really helping?
Expect a different kind of newscast. Fox 11 News Special Report. Weeknights at 7.
According to SAMHSA's national survey on drug use and health, approximately 20.3 million people above the age 12 suffer from substance use disorder. Incredible. The disease of addiction takes an average of 130 Americans every day. Sadly, the opioid crisis, which many consider the worst pandemic of our time, has been even further perpetuated by the spread of COVID-19. Since the start of the coronavirus outbreak, drug overdoses have increased by 18%. Factors like economic stress and social isolation have led to increased depression and unnecessary deaths. A Better Life Recovery is a premier addiction treatment center in Southern California, offering one of the most highly regarded and comprehensive addiction treatment programs in the United States. Dedicated to helping its clients achieve complete inner and outer transformation, they offer a 45 to 90-day program custom tailored to meet the needs of each individual client. Long-term is the way to go. Many of A Better Life's clients elect to stay up to 9 months to receive additional support. A Better Life Recovery will do whatever it takes for as long as it takes to ensure the success of every client. Are you ready for a better life? Go to abetterliferecovery.com or call 866-581-4401 now.